Shields talking about melanoma is a damning fate, but we'll do that. And I was asked to address what were some of the controversies in the field for us. So I'm going to run us in a short period of time through some of what I think are the interesting controversies. And this room hosts some of the major experts in the field. I don't really have any significant financial disclosures, and some of the approaches to care we'll discuss are off-label. I think that the areas that I find interesting are the controversies in the management of small uveal malignant melanoma, the treatment of radiation-related retinopathy, and the approaches to use non-radiotherapy in globe-sparing treatments for malignant melanoma. And it's important to recognize that people talk about the collaborative ocular melanoma study often, but that study presented its first results in 2001. And our field has moved so far past that. So I want people to be aware of those numbers, always keeping that in the back of your mind. But I think that that really doesn't define the field of uveal melanoma management at this point. But remember, melanoma-specific mortality at 5 years for small tumors was 5%, for medium tumors was 10%, and for large tumors was 30%. There's much discussion about a 50% mortality rate for uveal melanoma, and I think at most of our centers that really doesn't exist. And then the other thing is we should pride ourselves on how accurate we are in our diagnosis, because we haven't really used biopsy for diagnostic purposes. We're going to talk about biopsy for the purpose of pathogenesis and understanding risk to potential metastatic disease. So there was no difference in 2001 reported between enucleation and I-125 brachytherapy. The Shields, in fact, prior to that had moved the majority of their patients to brachytherapy, but this was a pivotal point in the US to move the country toward brachytherapy. It excluded small tumors, it excluded very large tumors, and it excluded juxtapapillary tumors, all of which now are routinely managed with brachytherapy at top centers. It's important to recognize during that trial that we had routinely done preoperative metastatic screening, but for the patients that present to you, less than 1% of your patients with a complex melanoma will have metastatic disease from the melanoma, but 10% of your patients may have a coincident independent malignancy. Breast in women, lung in men being the two most common. And it's important for all of us to remember, where does this tumor metastasize to? And we've been taught liver, lung, then skin and cutaneous tissues, and that remains true to this day. So the CMS trial showed a 90% tumor control rate. I think in this room, tumor control rates for brachytherapy now for all comers, small, medium, and large tumors, almost approaches 100%. And the melanoma-specific mortality rate in that trial, as we said, was approximately 10%. For us, with some of the genetic screening profiles and some of the advancements to earlier treatment, we've seen a lowering of that. Also remember, for patients treated with brachytherapy, the median visual acuity 36 months after plaque, so the 3-year after plaque median visual acuity was 21-25. These patients were essentially legally blind in that eye. So what's the small tumor controversy? I think really the small tumor controversy has focused not so much on those of us in this room, but really has focused on the concern of the potential to mistake an atypical nevus for a small melanoma. And that has really shied us away from treating small melanoma patients, particularly when treatments had significant morbidity, either enucleation or radiation retinopathy. But I think, in fact, for those of us taking care of these patients, diagnostic accuracy for small tumors is almost identical to diagnostic accuracy for large tumors. The COMS used a treatment plaque that treated all patients as if they had a 5mm thick tumor, and in fact, we and Gary and Carol had not done that from the beginning, or we treat patients to the apical height of their tumor, typically with the 2 millimeter margin around the tumor itself. So one of the things that's interesting is how do we do these plaques? And so the eyes are opened, we engage the 4 rectus muscles, we utilize a transillumination for us to evaluate the tumors that we can see anteriorly, and that allows us to localize the tumors. Many of us confirm the tumor localization with intraoperative wide field imaging and then with intraoperative echography. After the tumor is confirmed, we move the plaque onto the field. You can see how nicely this transilluminates here. And then in virtually all of the tumors that we're treating now, we'll then biopsy the tumor, either with a transscleral biopsy for anterior tumors or a transvitreal tumor. This is Fiona, who's an amazing photographer. At our institution, we routinely use intraoperative ultrasound. For people that are expert at this, like the Shields, I don't think that is necessary, but for those of you that maybe are less experienced, I think it's a critical component. And then we look for centration of the plaque with margin. One of the things to recognize is that radiation retinopathy is ubiquitous. Expect to see that in virtually all of your patients. For small tumor patients, expect that the outcomes now will be quite good. We expect a mortality rate within 10 years for our patients, typically of under 2%. Patients, when they do metastasize, have that same differential. The other thing to realize is that when patients do develop radiation-related complications, they are now treatable. And the controversy in radiation retinopathy at this point, I believe, is no longer do we treat or do we not treat. It's about when do we institute therapy and how often do we treat. There's been some excellent studies by the Shields and others that have suggested that ongoing prophylactic therapy is beneficial. At our institution, we follow closely with SWEP source or spectral domain OCT of the macula. When the macula is affected and the vision is impacted, we institute therapy. Routinely, these patients need to be treated every 6 weeks. What was interesting is we grossly underestimated radiation retinopathy in the COMS because we did not have access to OCT. Photography is really a poor man's ability to evaluate radiation retinopathy. And this was the 5-year evaluation of the first 140 eyes that we treated. We used the Shields modified grading scheme, and patients were treated initially with anti-VEGF therapy. Because this is off-label, we have typically used bevacizumab for our treatment. We've supplemented bevacizumab in complex eyes with triamcinolone acetonide. We recently published the 1-year and we'll publish the 2-year results of aflibercept. I truly believe that the choice of anti-VEGF makes no difference in outcome. It just requires early treatment and aggressive ongoing care. So the entry visual acuity for this series was 2100, and the central point thickness of the OCT was 487 microns, and with a 5-year study follow-up, we saw significant improvements. In this study, it was approximately 10 months till we developed OCT findings to institute therapy, and the follow-up was approximately 6.5 years in institution of care. This is a 76-year-old who's 11 months after brachytherapy, has a 6-week decline in visual acuity, and you can see that after the first time we administered the bevacizumab, there at 6 weeks he got worse, we delivered triamcinolone, he got better, and here we are now at 5.5 years, and vision in this eye is 20/30. And we had truly not seen that before anti-VEGF approaches as an option for our patients. And you see here a 79-year-old, a year and 2 months after, same thing. In this patient, bevacizumab supplemented with steroids. Using aggressive anti-VEGF therapy, either with aflibercept or with bevacizumab, is effective, but triamcinolone may be required in these complex eyes. The take-home message is that 12 months vision had improved to 20/50, and it was stabilized over the 5-year follow-up, with 90% of the patients having 20/60 or better vision, and 50% of the patients having 20/40 or better vision. But they got on average 5 injections a year with an anti-VEGF and 2 injections a year with the steroid. So remember that we now have the opportunity to treat radiation retinopathy. We know that early treatment for small tumors is important. And then I'm going to conclude with the last, which is the importance of biopsy management. The Shields have really been active in pioneering with some of the investigators in this room, the Aura Bioscience trial, which is treating small tumor management, avoiding radiotherapy. Our approach to that has been a little different. We've utilized laser tumor ablation during vitrectomy with biopsy. And I think the critical take-home message is people have been concerned about the risk to benefit ratio to biopsy, and I think that the take-home message is that every patient should be offered the opportunity to have biopsy for either genetic karyotyping and analysis or with genetic analysis using GEP testing. So having said that, I'd like to thank you all for including